Welcome everyone to today's Cerebral Palsy Alliance research webinar, The Earliest Interventions with Dr. Zachary Vesoulis, where we'll learn about neonatal brain injury. This webinar is closed caption enabled, and we've turned on auto transcription as an accessibility feature should you need it. I want to let you know about the Q&A function on this webinar as well. You can type your questions for Dr. Vesoulis by clicking on the Q&A icon, and we'll get to as many as we can after the main presentation. I'm Jocelyn Cohen, Vice President of Communications and Engagement with Cerebral Palsy Alliance Research Foundation here in New York City, also known as CPARF. And it's exciting to have you join us today, whether you're on your lunch break, just starting your day, or somewhere in between. Over the last several years, CPARF has funded research into different NICU interventions, including 2 of Dr. Vesoulis' projects. And we're thrilled to have him here with us today to share his expertise and insight about the science he's worked on and how it can positively reshape care. Dr. Vesoulis is an assistant professor of pediatrics at Washington University in St. Louis and the co-director of the Neuro-NICU program at St. Louis Children's Hospital. He earned his bachelor's degree from Miami University in 2005, his medical degree from The Ohio State University in 2009, and his master's in science from Washington University in 2019. Please welcome Dr. Vesoulis.
Thank you so much for that wonderful introduction. And I really appreciate the opportunity to speak with you all today. I'll be going through sort of my experiences as a neonatologist and then how that intersected with the research that we've been doing and hopefully how we can use this to make a big impact for babies going forward. My computer participate. Oh, there we go. So I have no disclosures for the talks today. So one of the things that we deal with the most in the NICU is trying to predict the future. We often feel like we're asked if we have a crystal ball to try to understand where things are going to go for babies. And the questions that we're asked or we ask of ourselves are very different. So many of our parents want to know things like, will my baby survive? Will they even make it out of the NICU? If they do, how long will they be in the hospital? Will they have problems in the short term or in the long term? On the doctor side, we have many of those same questions that the parents do, but we also have ones that are more about the short-term care of the baby, medical management. What kind of complications might this baby have? Can we predict, will they have these complications or even prevent them? And then something we often are faced with is trying to decide, is this baby ready to go home? Are they in a stable enough spot that they'll be able to go home and thrive? And then one of the major topics we're going to talk about today is what sort of implications has what's happened in the NICU have for the future for these babies from a neurologic perspective. So one example, so I'll talk about a number of babies I've taken care of over time. I've changed and obscured some of the details just to protect privacy. And this is not actually the picture of the real babies. This is one from the internet, but the idea is the same. So a number of years ago took care of triplets that were born at 24 weeks. The pregnancy had been completely uncomplicated, and there were no issues whatsoever. And the mom woke up in the middle of the night bleeding. She had an abruption where the placenta was separating from the uterus. So she came to the hospital. We had to do an emergency C-section, and the babies were born. It was 2 or 3 o'clock in the morning. But even though these babies are identical, they have the exact same genetics, they came from the same parents, the same environment, they were in the same NICU with the same doctors taking care of them, all 3 of them had very, very different outcomes. So one of them had cerebral palsy. One of them had really difficult challenges with their intestines, had lots and lots of surgery and lots of complications there. And then one of them had a lot of trouble with their lungs. So they all had complications, but completely different ones. And the challenge, the thing we struggle with is why? How does something like that happen? And how can we predict it in the future? Another example, this is from a really fantastic article that was published by the mom and dad of some twins in Canada. They both have PhDs in science fields, although not medicine, and had 25-week twins named Marin and Lily. And they talk in their in this commentary about their experience in the NICU. So they had really challenging courses for their twins. One of them unfortunately passed away, but the other one, after a very long and bumpy course, had made it to discharge. They did an MRI before she went home and saw some things on the MRI that made the doctors worried, but the doctors weren't sure, what does this mean in the long run? They might have problems. They might have difficulty with learning in school or with motor skills, but our ability to predict is not that good that we could say for certain. So these parents were both very, very worried for the next few years. And by the time Marin, who's pictured at the bottom here, these are both pictures from the article, turned 4, she had formal developmental testing and everything was great. She had normal cognition, she had no motor impairment at all. And they wrote this commentary because they really wanted to express how distressing for parents this uncertainty of the future is. And it's something that's very humbling for us as neonatologists all the time. Even though this is so important to predict the future, the tools that we have right now just are not that good. We feel very confident when babies have negative findings. So if we do an MRI or an ultrasound and we don't see any problems, we feel pretty good saying that babies will have good outcomes. But if there's something on there, we don't know what that means. And when we've tried to come up with ways of predicting things in the future, there's a couple of different ways we've done it. One is sort of the classic qualitative approach. That's the expert opinion. This is people making guesses based on their experience, based on other patients they've taken care of in the past that are similar to this one. But that's going to be subject to a lot of different kinds of biases. We've come up with slightly more advanced systems where we use clinical factors. So we look at how early were they born, were antenatal steroids given, what was the birth weight, and use those to try to predict the future. I've already talked about imaging, where we use things like head ultrasounds or MRIs to try to predict outcomes. But all of these struggle to predict the future accurately for families. And in particular, there's something I really wanted to focus on, this idea of negative and positive predictive value. So the negative predictive value is how accurate are you when you're saying that there won't be a bad outcome or there won't be problems. How accurate are you when you say that won't be the case? Versus positive predictive value is when you do think that there will eventually be some problems or issues, and how accurate is that? So those are two sides of accuracy. We're pretty good with the negative predictive value part. We're not very good with positive predictive value. So the basis of a lot of the work that I do is trying to develop a new approach. Instead of looking at these clinical factors or imaging factors, I want to look at baby's physiology, because I think that tells us a lot more about what's happened to the baby while they're in the NICU. There's several different scores. One's called the crib score, one's called the SNAP score, that tell us the risk of a preterm baby dying in the NICU. And those are based on birth weight and gestational age and a couple of other things that come up in the first 24 hours of the baby's life, which are important in that first 24 hours. But once we get further and further away from that 24 hours, those things are less important about that baby's outcome. But that score doesn't change. They have that same score the entire time that they're in the NICU. My thought is that we can use their physiology. So what is going on with their heart rate, their blood pressure, blood flow to their brain on a continual basis. All of the babies in the NICU are connected to monitors that provide constant updates on this information. And we can do something with that. We can use computers to find patterns in that help predict things based more on what's actually happened with the baby rather than something we knew right when the baby was born. So I call this the physiologic phenotype of a baby. And my goal is to try to improve that positive predictive value. So when we have some sort of abnormal finding, identifying whether that finding has long-term meaning. And the reason that we want to do this is that we can use this to customize interventions for babies. There are many things we do to improve neurodevelopmental outcomes for babies in the NICU that are great. There are lots of developmental care strategies we've used, different ways that we use medicines now, the use of things like antenatal steroids, so steroids given to the mother before the baby is born. But we give those to all babies, regardless of their risk. There are other things that we would like to do for babies, but might be a little more complicated to do, or might have some other risks associated with them. So we want to really focus those interventions on the babies that are the most likely to to get benefit from it. So ideally, this is what we would have: a computer system that's constantly monitoring things in the background, and it spits out exactly what the risk of the problem is, and specific recommendations of what we should do to fix that risk factor, to try to intervene early to change the outcome of this baby. Something like this does not exist right now. What we have instead looks more like this. So this is our electronic medical record with huge amounts of information. It's a fire hose of information that's coming to us. And we're supposed to find patterns in this to try to predict problems in advance, make early interventions. And that's a challenge, especially when you're taking care of a lot of babies all at the same time. This is a great opportunity to have computers and algorithms help us sort through this information, find that important signal and all of this noise, and alert us early to problems with babies so that we can make those interventions. So there's a couple different targets that we've looked at in our research group that I want to talk about today, specifically to give you an idea of what is out there so far and where we're planning on going in the future. So the first one is blood pressure. That's one area that we focused on. Another is hypoxia, so low oxygen levels. And this can be in the body, it can be systemically, or in the brain. We've looked at both. And then also how blood flow is regulated going to the brain, and how do risk factors like prematurity, for example, impact that blood flow to the brain. So if you ever ask a neonatologist, what is the normal blood pressure in a preterm baby, you'll get about as many answers as neonatologists as you ask. The reality is that we don't have a good handle on it. Lots of different people have looked at it, including our group, with lots of different measurement devices and making fewer measurements or more measurements. And we're starting to have a pretty good idea of what a normal blood pressure looks like. What we still don't have a good sense for is, what does the blood pressure need to be? That's the most important question. It's great to know what the blood pressures were in babies that had great outcomes, but we don't know how much lower it could have gone before those babies had problems. One way that we've looked at this in the past is, how do babies respond to medicines that we give them? So one medicine we use a lot to bring the blood pressure up in preterm babies is called dopamine. And it's a hormone that's secreted by our bodies naturally. We give extra amounts to babies to get their blood pressure up. And we had the observation, taking care of babies, that there are some babies we give dopamine to and their blood pressure comes up a little bit just like we expect it to. There are other babies we give just a little dopamine and their blood pressure goes up a ton. And then there's a third group where the blood pressure doesn't really change at all. So we found a bunch of these babies and looked through all of their records and found that not only is this pattern true, that babies do fall in these three groups, but their response to this medicine influences their brain injury risk. So the babies that don't respond to dopamine at all have a much higher risk of bleeding in their brain, or intraventricular hemorrhage, sometimes called IVH, compared to the babies that are super responders, that have a ton of response, even to a little bit of this medicine. They have a substantially reduced risk of brain hemorrhage. So our response to medicine gives us an idea of their injury risk. So this is moving things beyond where we were before. So now we're talking about the physiology, how this baby's body is actually changing in response to medications, and trying to come up with some prediction about the future, particularly brain injury risk, based on that. Another tool that we use really commonly, and the two projects that the Cerebral Palsy Alliance Research Foundation has funded of mine, both use this technology called NIRS. And it uses red light. It's similar to a pulse oximeter, if any of you have ever seen one of those before. And it's red light that can be applied to any organ of the body. We typically use it on the brain and in the abdomen. You can see this picture here. This is actually a mannequin. This is not a real baby, but we have it under the strap on the head there. And then we also have it tucked down in the diaper so we can measure oxygen levels in the intestines. This technology uses light to figure out how much oxygen is attached to the red blood cells in the body, our oxygenation level. And it's something that's non-invasive. It doesn't hurt the babies. There's no poking or pain associated with it at all. So they tolerate it really, really well. And it makes it a great tool to continuously monitor oxygen levels in different parts of the body. There's been a lot of work that have been done by our group and others trying to figure out what is the normal oxygen level, especially in the brain. That's the area that's been studied the most. There's a really nice paper that was published out of Utrecht in the Netherlands 6 years ago, I guess now, where they looked at 1,000 babies and what the normal oxygen levels were in the brains of these babies. So that gives us a really good idea of where we need to intervene for these babies. So I talked earlier when we were looking at blood pressure about knowing what the blood pressures were in normal babies, but not necessarily knowing what it needs to be. With studies this large that have been done using the NIRS device, it actually starts to give us a hint of where we need to intervene. Each individual NIRS device, and there's a bunch of different companies that make these, have slightly different numbers, so we need to calibrate it to the specific machine that we're using. But what they found for the device that the folks in Utrecht were using is that the normal range is between 55 and 85. So if those brain oxygen levels start to go outside of that range, that is an indication that perhaps we need to intervene to change that, to get it back into that normal range. There's another idea called FTOE. So we can use a couple of different sensors. So we can use the NIRS sensor and we can use the pulse oximeter, which measures oxygen level in all of the blood of the body versus the oxygen level just in the brain. And we can use it to figure out how much oxygen a particular organ is using. We subtract them from each other. So if the oxygen level on the body is 100% and the oxygen level in the brain is 70%, we know that the brain is extracting about 30% of the oxygen that's in the blood. And that's pretty normal. Somewhere between 20 and 30% is about how much oxygen that the brain uses. In fact, the brain and the liver and the heart are the organs that use the most oxygen of all the organs in our entire body. Together, they use about 70% of all the oxygen in our body. So they're really expensive organs, I guess, in terms of oxygen consumption. So like I was talking about, we can use these NIRS monitors to potentially guide our management. If we see that that oxygen level is too low, it might be an alert to us that something is going on and we need to make an intervention. There was a phase 2 clinical trial. So this was an early clinical trial with a small number of patients where they were mostly looking at safety before they look at efficacy, which is what happens in phase 3, that was done with a number of centers in Europe a few years ago, called the Safe Boost trial. And they enrolled 166 babies. And when the oxygen saturations dropped below those limits, they had this whole bundle of different interventions that people could try. So the NIRS monitor doesn't necessarily tell you what you need to do to manage the baby. You still need to perhaps do additional blood tests or maybe x-rays or ultrasounds to try to figure out what's wrong. The NIRS monitor is just an early warning system. It tells us before any of the other monitors that the baby is attached to start showing any abnormalities, that something is wrong and that we need to intervene. And even though this study was designed for safety, there was an enormous benefit in the babies that were randomized to the NIRS group. So half the babies got just routine care with the monitors that we normally use to take care of these babies. The other half for 3 days used this NIRS monitor to guide that management. And so they found basically a 50% reduction in the risk of brain injury or death for babies that were randomized to the NIRS group, which is an incredibly unexpected finding. They were not expecting to see that much of a benefit. They were expecting to see some benefit, of course, which was the whole point of the study, but not nearly that much. And it was very, very exciting for us. This is not enough information to put this in regular clinical practice, but that's actually the second project that CPARF is funding. I'm the US coordinating center of a consortium of 6 US hospitals, St. Louis University, Washington University, University of Texas Southwest, Loma Linda in California, Nationwide Children's Hospital in Columbus, and University of Virginia in Charlottesville. The 6 of us are participating in this phase 3 trial, phase 3 randomized clinical trial, which is called Safe Boost 3 because it's a phase 3 study. And it's going to be 1,600 babies from all over the world. So there's more than 70 centers in Europe, Asia, and the United States that are using this exact same algorithm that they followed in the phase 2 study. So babies are randomized to normal care or NIRS guided care. And if babies' oxygen or brain oxygen levels drop below that threshold, then we intervene. And this is a table taken straight from our protocol here of the different types of things that we do to help improve the oxygen delivery to the brain of these babies. And the whole goal is to do this early, before there is problems, to try to prevent things from happening down the line, or if something is happening in the brain, to try to limit the extent of the problem or injury. We really appreciate the support that you guys have provided for us in this, where we have 3 sites up and running already. A 4th site is almost ready to go, and the last 2 we should be able to get by the end of the summer up and running. So we're really excited to be participating in this trial. This is something that I think will probably change our neonatal management across the world. If the phase 3 trial bears out to have the same benefit as the phase 2 did, every single baby around the world will get NIRS monitoring for the first 3 days after they're born to guide management like this, and potentially have an enormous impact on their mortality risk as well as their neurodevelopmental outcome. So we're really excited to be a part of this study. There's some other work that we have done that supports this whole idea, that we try to avoid hypoxia, so low oxygen levels in the body. I have a multi-center collaborative with the University of Virginia as well as Columbia in New York, where we've collected vital sign information from lots and lots and lots of babies. This particular study was almost 650 babies, and we had 163 million measurements of pulse oximetry. So this is not NIRS, this is just a regular pulse oximeter. So we have a ton of measurements from these babies, and we look to see how often babies had low oxygen levels. So part of the typical course in a preterm baby in the NICU, they will have periods where they stop breathing and their heart rate drops and their oxygen level drops. We rush in there and stimulate them or give them extra oxygen to bring it back up. But these events are unfortunately very common for preterm babies. We can do things like put them on ventilators that will reduce the risk of these events. We give babies caffeine that also reduces these events where they forget to breathe. But even with those 2 interventions, that doesn't stop them completely. So we wanted to understand, what is the long-term impact of having events like this? And so babies that have severe brain bleeds spend substantially more time with these really low oxygen levels, which is something that we suspected based on our anecdotal experience, but this is something we demonstrated with real data. So babies that have severe brain bleeds spend 3% of their time in that first 7 days after they're born with their oxygen levels in a very, very low state, so below 70%. For these babies, we ideally wanted above 90%. That would be a normal value that we expect it to be. So this is quite low. This is also important for other potential complications that preterm babies run into, particularly ROP, retinopathy of prematurity, which is a problem where exposure to too much oxygen, so this is on the other end of the scale, rather than the oxygen level being too low, this is now too high, where too much oxygen can cause the blood vessels in the back of the brain to grow very rapidly and can lead to things like blindness or retinal detachment. So it's a very important problem, and we keep a very close eye on. And one of the main things we do is try to limit the oxygen saturations for babies within a very narrow target. So we want their oxygen level to be above 90, but less than 95. That's sort of the sweet spot that we've identified as the goal for reducing mortality on the low end and brain injury, but also reducing the risk of this eye problem too on the high end. In this particular study, this is something that I worked on with one of our fellows a few years ago, where we compared pulse oximetry, which is what we use right now, to the NIRS device that I talked about, thinking that the NIRS device, because it's brain oxygen level, and the eyes and our brain share the same blood supply, they both come from the carotid artery in our neck. So they're very close to each other in terms of their blood supply, that the NIRS device actually might be more specific and give us more information about ROP risk than the pulse oximeter. And in fact, it does. It's a much more accurate device for predicting ROP in babies. So this is another example of how we can use a more advanced technology, something like NIRS, to guide our management in a much more specific way for an individual baby than what we're doing currently. Something that we published last year that was funded by CPARF. This was the first grant that you guys generously provided, which was a longitudinal study. So most of the NIRS work that I've been talking about so far has come from the first 3 days. That's a really important time period in the life of a preterm baby. That's when they have many of the complications. It's the highest risk period for bleeding in the brain or for mortality. But the rest of the NICU course is also important. And in the past, no one had done continuous monitoring after those first 3 days. So for this particular study, we did daily NIRS monitoring for the first 2 weeks. We did every other day for the next 2 weeks, and then every single week until the babies were 35 weeks corrected. So if a baby was born at 24 weeks, for example, we would do monitoring for 11 weeks total. This was to try to figure out what happens after those first 3 days. Very little was known about that. There were 2 factors that we were really interested in looking at. So one was brain bleeds. So babies that do have bleeding in the brain very early, what's the long-term impact on the brain? We know that it causes oxygen levels in the brain to drop in the short term, but we had no idea what happens in the long term. The second thing we wanted to look at is anemia. So anemia is a really common problem for preterm babies. Part of it is because we're constantly taking blood out of them for all the lab tests we do. That's compounded by the fact that preterm babies aren't really able to make red blood cells on their own until they're several months old. Their bodies just are not quite ready for that yet. So we were interested in understanding the impact of anemia and brain bleeds on the oxygen levels in the brain. So this chart that I show here shows hemoglobin. So that's our measurement of anemia. And ideally, we want that to be above 10 in preterm babies. And how does oxygen levels or oxygen saturations change as you become more or less anemic? And sure enough, the lower your oxygen levels go, or the lower your hemoglobin goes, the more anemic you are, the lower the oxygen levels in your brain go. This is important because this will help us guide another intervention, blood transfusion. So we give blood transfusions pretty frequently to babies in the NICU. But one of the challenges that we face is we don't have a good target necessarily of when to give that blood transfusion. There's a couple of different proposed thresholds. Some people do transfusions when the hemoglobin is 8. Others do it when it's 10. And some of it depends a little bit on how sick the baby is otherwise. But we don't have good data-driven metrics like what I'm showing here to guide us in those blood transfusions. So having information like this, what is the oxygen level in the brain? Is it in the normal range? Will give us much more personalized interventions for babies to give a blood transfusion when it's definitely needed. But if it's not, then we don't want to expose babies to blood products. So that helps us really target our interventions in a much more streamlined, specific way. The next thing, like I mentioned, we wanted to look at how does bleeding in the brain affect oxygen levels. So all these dots here represent individual babies and individual recordings. The babies that had bleeding in their brain are represented by black dots. The ones that didn't have bleeding are blue dots. And we look at that with our eyes, and it's very difficult to sort out the pattern. You kind of can, maybe if you squint a little bit. But we can use computers to find that pattern for us. And that's what those lines are. The blue line and the black line represent the average of those dots for those 2 groups. And you can see baby on the x-axis along the bottom there is the age of the baby. So this is the number of days since they were born. And on the y-axis, this is the oxygen level in the brain. So for these babies, you can see the ones with brain bleeds have much lower oxygen levels in their brain. And it continues to drop, and it is lower at every single point for the first couple of months after these babies are born. So this low oxygen level in the brain is not just a short-term problem, it's a long-term problem. The overall shape of the 2 lines is pretty similar, and this is being driven by that anemia process. These babies, as they get older and older, become more and more anemic, which is why both of them go down to some extent, but it is lower in that group of babies with bleeding in their brain the entire time. This is true if we separate babies out to those with no bleeding, which is the green or turquoise maybe line here, compared to ones with mild bleeding. So just a little bit of bleeding, but not severe, which is the yellow line. And then the babies that have severe bleeding is the red one. And there's a continued separation. The worse the bleeding is, the lower the oxygen levels are in the brain. we can do that oxygen extraction measure that I talked about earlier that tells us how much oxygen the brain is extracting. And you can see the babies that have injury are the ones that have more extraction. So in fact, the extraction amount is way above that 30% range that we talked about. These babies are extracting a lot of oxygen from the blood that's being delivered to the brain, which means that brain is under a lot of stress, that there is ongoing hypoxia or low brain oxygen levels, and the brain is trying to get every single molecule of oxygen that it can out. Now you'll notice on the right, I've actually changed the legend here. This is a different kind of brain injury. The last two I was talking about bleeding in the brain, IVH. This is white matter injury. So this is a long-term injury that can occur in babies, particularly those that have had IVH are at much higher risk for white matter injury. And white matter injury we know is one of the largest risk factors for cerebral palsy in preterm infants. So this really gives us an idea about mechanisms of how you can go from the bleeding initially to incredibly high oxygen extraction in the brain, which is happening over the period of months, to long-term injury in the white matter, which is a mechanism for potential neurodevelopmental problems down the line. So I'm going to talk briefly about autoregulation. So I spent a lot of time there talking about oxygen levels. Now I'm going to talk a little bit about blood flow to the brain. So we've known for a very long time that the brain has a really interesting mechanism in it that helps to control blood flow. It's a really, really smart organ that knows across a whole range of blood pressures how to change the blood vessels clamp down or they widen up to regulate that blood flow so it stays the same. The brain has a really nice constant blood supply no matter what you're doing. So that's if you're flying in an airplane or you're laying flat or sitting up, the brain controls that blood flow perfectly the entire time. But there's limits to that though. Sometimes the blood pressure can be too low or too high, and that the compensation can't happen. And that's where we worry about brain injury. And this is just as true for adults as it is for babies. One of the challenges that we have with babies is that we don't know what these upper and lower limits are. We have a pretty good idea of what they are for most adults, but for babies, it's something that's still really uncertain. So ideally, what we would like to see is the blood pressures. If you look at the blue line on the left here, blood pressure in babies goes up and down all the time because we're all living creatures and our bodies are constantly in flux. Things are always changing. What we want to happen is our autoregulatory system, this black box right here, modifies and changes that fluctuating blood pressure into blood flow into the brain. That's just what the brain needs. So the ups and downs in the blood flow in the brain, which is this green line here, match what the brain needs, not what the body is supplying. What we don't want to happen is the red line here, where autoregulation is not working. And so the brain is getting exactly the same ups and downs as coming from the body, because that means that some of the time it's too much blood flow and sometimes it's not enough blood flow. So we really need this autoregulatory system to smooth it out for us. So we wind up with the green line. The autoregulatory system is a black box though. We have no idea, or there's not really a way to directly measure what autoregulation is doing. What we can do is see what's happening on the input side, the blue line, and the output side, which is the red and the green. And then we can figure out how this is functioning by looking at the beginning and the end. There's a lot of different ways that people have done this, and most of these involve quite a bit of math. But we're coming up with increasingly sophisticated ways of doing this because they give us more and more information about this function. One of the most straightforward ways to do it is to look at correlation. So if you have intact autoregulation, intact control of blood pressure and blood flow to the brain, you would expect to see little correlation or even negative correlation between blood pressure and blood flow to the brain. So that would be that example from a couple slides ago where these two things are not related to each other. There's no correlation because autoregulation is intact. This blood flow is being driven by the brain. When there's high correlation between these two, that's because something has gone wrong with the autoregulatory system. So we can actually figure this out. And this is a project we did a few years ago using our NIRS device again and the blood pressure of the babies. And we look and see across all these different blood pressures, that's what's on the x-axis here, what the average correlation is. So this is the correlation. Correlation values go between 1, which is completely correlated, 0, which is no correlation, and -1, which is oppositely correlated. I don't know if that's the right word to use. But what we want it to be is either 0 or negative. So that's green. So you can see this baby across a whole range of blood pressures has negative or close to 0 correlation, which is perfect. That's autoregulation is active and doing its job there. But when the blood pressure starts to get too high, that's the red bars here. And that is a sign, that's a worrisome area where autoregulation is not functioning how we want to. Same thing on the lower hand side. When the blood pressure starts to get too low, we worry that there's unregulated blood flow happening to the brain there. In a group of babies that are term infants who had HIE, so hypoxic ischemic encephalopathy or birth asphyxia, where something went wrong during delivery and there was not enough oxygen going to the baby for a period of time. We've looked at this and found what those average limits are between the upper and lower limit. And this is a little bit higher, this lower limit, than what we would generally think is a normal blood pressure for babies, suggesting that maybe we need to be a little bit more active in our blood pressure management to keep them in that green bar range, so that we're not putting them in this risky period right here. This is again another example of using technology and these algorithms to come up with individualized management for babies. We looked at babies that had injury on their MRI afterwards, and actually we found that, and we looked at using these limits, these upper and lower limits, we saw that for the first couple of days after the babies were born, both groups, those with injury and those without injury, they kept their blood pressures between those limits. They went up and down a little bit here and there, but for the most part, they stayed in that range. But the babies who had injury had this really late period where their blood pressures went really high, really out of that range. And those are the babies who had injury on MRI later, suggesting a potential target and even a time frame where we could intervene. What's going on with these babies during this time frame? How can we move this blue line back down below those limits, with the goal of trying to reduce or eliminate injury? We've looked at similar sorts of things in preterm babies. So this is back to the idea of oxygen extraction. How much oxygen are you extracting? And we looked at this across a range of blood pressures. So you would expect for anybody, not just the preterm baby, that the lower your blood pressure gets, the more oxygen your brain is going to extract. Because your blood pressure is lower, you're delivering less oxygen. So the brain's going to want to take more of that oxygen out of the blood that is making it there. And then as the blood pressure gets higher, you'll extract less and less and less because so much blood is going to the brain, it doesn't need to extract as much because there's plenty of oxygen to go around. So we looked at this for two groups of preterm babies, ones that are 26 to 28 weeks, so definitely preterm babies, but older preterm babies. And we compared them to a group of really preterm babies, so those 23 to 25 weeks. And for the older babies, those with this dashed line here, they did exactly what we expected them to. So as their blood pressure dropped, their oxygen extraction went up, and as their blood pressure was higher, it went down. So the response we expected it to be. For the preterm babies, they did exactly the opposite, and they're doing exactly the wrong thing. So when the lower the blood pressure gets, the less oxygen they extract, and the higher it gets, the more oxygen they extract, which means that their autoregulatory system is not working, or it's not working as well as we want it to. In this middle range here, it's working just fine, those normal values. But we also saw that this problem started to occur when the blood pressure dropped below 30, which is actually a threshold people have proposed in the past, is one that we should be using to guide our management of these babies. This is some nice real world data that we can use to inform that decision. We've looked at autoregulation a slightly different way, using something called transfer function analysis. And I won't get into the technical details behind it, but what this does is looks at oscillations. So when we think of blood pressure or heart rate, we think of these things as kind of steady numbers that are, our heart rate is 65 beats per minute, and it stays there, as long as we're, sitting in a chair, watching a presentation. But if you look at a really minute detail, there's actually a small fluctuations. Our heart rate or our blood pressure are constantly moving up and down by little tiny bits. And that variability in it is a sign of health. So that's a sign that our nervous system, particularly our autonomic nervous system, is healthy and doing exactly what it's supposed to do. And these vibrations in those signals occur at really characteristic frequencies. In particular, one called the Meyer wave frequency, which is 0.1 hertz, so once every 10 seconds. So that's a little vibration in your blood pressure every 10 seconds. And that's a sign of health, that's good. In fact, the guy that discovered this is named Sigmund Meyer, discovered this back in the 19th century with a bat. He caught a bat and he held it up to a candle and looked at the blood vessels in the bat's wing. Since the skin is so thin, you can actually see the blood vessels. And he noticed that every so often, those blood vessels would change. They'd get a little bit bigger or a little bit smaller. And so he got out a clock and he timed them, and it turned out they were every 10 seconds. So it's not just humans that this occurs in, it happens in all sorts of mammals. And it's a regular process that happens subconsciously without us even thinking about it. So we were very interested to see how this played out in preterm babies. We know that these vibrations at this frequency, this once every 10 seconds, are very strong vibrations, and something like the brain would really want to smooth out because it doesn't want those strong vibrations getting to the brain, which would give it too much blood flow over a very short period of time. And so it turns out that the brain actually dampens it. So you can see at 0.1 hertz right here, that there's a little bit of a dip right here. And it's actually true for all of the babies that we're looking at here. And this is the brain trying to dampen out those little vibrations. But you can see this is all color coded here based on the gestational age of the baby. The more mature the babies are, the better they are at dampening out those vibrations. And the ones that are the most preterm, the 24 and 25 weekers, have not nearly as much ability to do that. So these are all individual indications that show us about that autoregulatory system and how it's functioning, and how that might influence their risk of brain injury. So how do we put all this stuff together? These are all very interesting projects that we've done, but how do you put this together to actually do something in the NICU with it? So one of the main problems that we have right now with our prediction models, and I talked about this a little bit at the beginning, is that they all focus on one specific silo. So they are imaging scores, or they are clinical scores, or sometimes they're based on just the NIRS device or just an EEG, so something that's looking at seizures, for example. The problem is that when you look at only one domain of information, it's just a tiny little sliver of what's going on with the baby. And we're missing a ton of other potential information. So a couple examples here. So on the left is a AUC curve. So this is basically just tells us how good the prediction is for a system. We developed a strategy for reading MRIs for babies with HIE or birth asphyxia a number of years ago. And it's a 48-item checklist. You go through all these different parts of the brain and different sequences on the MRI and add up the score, and that predicts a moderate or severe neurodevelopmental outcome for these babies with modest accuracy. So an AUC of 0.72 is modest accuracy. We used, and it's a different patient population, but the idea is the same. A year later, did something with preterm babies with an MRI scoring system. But we looked through a whole bunch of different candidates of imaging findings, clinical factors, things that occurred during the baby's hospital course. And we evaluated all of them to try to come up with the ones that were the most predictive. And we wound up, we had one model where we put every single variable in, which was a ton of variables. We put in where we did a mix of the two, and then we did another one where we did a slim model. So we reduced it to just the really high performing factors. And we found out with just 4 items, so much less than the 48 item system, we could predict with even more accuracy. So using more factors is not always the right answer. It's using the right factors. But something that was different in the scoring system that we came up with was that we used MRI factors and clinical variables. We used different types of information that gives us a broader understanding of what actually went on with that baby and wasn't just so focused on one particular domain. Something that is a really important component to all of this is how to convey this information to people. So a lot of the slides that I showed today have cool, pretty pictures and really interesting algorithms and math, but that's something that's not very useful clinically. It's something that I do on the computer in my office long after these babies are discharged. So one of the challenges is how can we communicate this information to providers at the bedside where people can actually make an intervention. One potential pathway is this system. It's called the HERO system, which was developed at the University of Virginia, and it uses heart rate variability. So it actually looks at those vibrations in the heart rate to predict sepsis, so a serious bacterial infection. Very different topic, but the way that they've decided to display this information, I think, is a really good example of potential pathways forward. So you can see the green line there is the heart rate of this baby over the time period that's shown. And the orange line is what the computer is calculating as the risk of sepsis. And you can see it's very, very low for a while, and then suddenly it really takes off. And what this is actually giving us is an odds ratio. It tells us what are the odds of this baby developing sepsis in the next 24 hours. So this baby has 260 times the baseline risk of developing sepsis compared to a healthy baby. This is a really powerful way, I think, to communicate this information to providers that tells them not only about where the baby is right now, but what has been happening in the recent past. So it gives you an idea of trajectory too. This is important to help us guide those very specific individualized interventions for babies tailored to exactly their particular circumstances. So there's a lot of steps between these algorithms and something that we use at the bedside. There's a couple of different paths that we can take in this. So one is short-term, what's called clinical decision support. So this is tools that doctors and nurses use to try to understand what's going on right now with the baby and make an intervention. The SafeBlue study I mentioned earlier is one of those. That's something we're actually doing right now, where we're using a new device, new technology, to give us more information about a baby to make decisions in the moment to try to change the outcome. The other area that we need to explore is more of the crystal ball. What do all of these things we know about this baby mean for their long-term outcome? And how can we do that in the most accurate way possible? So we're going to need to be really careful about what information we use, which I talked about. We need to limit it to the most relevant factors and the fewest number of points that we can get away with while still having it be predictive. That will make something that will actually be used by people. If it's really complicated, nobody will use it. And we need to really get that positive predictive value. We need to identify what is a normal outcome from not a normal outcome and do that accurately. So there's lots of different potential projects we can do. We can look at autoregulation, we can look at oxygenation, we can look at lots of artificial intelligence-based systems or machine learning to try to improve this prediction. So there's quite a few steps. And with the generous support of CPARF, we're really well on the way to coming up with these different systems for the future. So this is definitely a team sport doing all of this work. So there's a lot of folks here at WashU that are a huge part of our research and help out with recruiting patients and collecting data and helping to make all this stuff possible. I've got some fantastic collaborators at our other universities that we work with, and then all the generous support of our different funders, including Cerebral Palsy Alliance Research Foundation. So with that, that's all the slides that I had prepared, but I would love to answer any questions that you guys might have.
Thank you for that, Dr. Vesoulis. That was quite enlightening. I knew some pieces of that information from before, but just learning the background and how all the different variables interact with each other and affect the way that an infant is treated is fascinating, and it's really helpful and important to know. While we wait for people to potentially add questions, one that I had is what's your outlook on rolling out NIRS, globally? I know you're doing the 6 different centers. Are there particular challenges you anticipate, assuming the study goes the way that you expect and want it to?
Yeah, that's a great question. So there are some places that actually are not participating in the study because they've already started using NIRS. So they feel that the evidence that's already out there is so strong that they should already be taking care of patients with this. That's not typical of most sites, though. Most won't actually see this evidence. But if it comes out the way we expect it to, I do think it'll change the standard of care. That said, that changing that standard of care is going to be tricky for places. NIRS monitors aren't cheap. They're about $25,000 to $30,000 a piece, and the probes that we use to monitor babies are $150 a piece. So even if we're doing a single organ, if we're just looking at the brain alone, that's a significant cost. Something that should be accessible for most tertiary NICUs in the United States and Canada and Europe, but it's going to be a huge potential factor driving healthcare disparity for low and middle income countries that already struggle to keep up with technology, medical technology.
Yes, that is definitely an ongoing frustration. Just a question, because you talked about the monitors and the probe. So can the monitor be reused, and then the probe is the thing that has to get swapped out? So at least it's the quote unquote cheaper part of the monitoring system.
Exactly. Yeah, they operate on the same sort of system as printer cartridges and razor blades.
Okay. Okay. One other question I had, just having been born in the early 80s at 29 weeks and having cerebral palsy myself, you're talking about a lot more current information, but do you have an idea about how the prevalence of hypoxic injuries has changed over the last several decades? Because I know even when I was a child, they were talking about, that this wouldn't really be an issue in 10 years. And here we are nearly 40 years later, and it's still something that's pretty prevalent.
Yeah, there are a couple of factors that have changed. I was actually having a conversation with one of our senior nurse practitioners just yesterday, talking about the pulse oximeter. So that was one of the types of monitors that I talked about today. And back when she first started as a NICU nurse, around that same time frame, about 30 to 35 years ago, the pulse oximeters were brand new, and they had one pulse oximeter that all the nurses would sign up to use, and they would put each baby on for 30 to 60 minutes, and they would make adjustments to the ventilator or the oxygen level while the pulse oximeter was on, and then they'd take it off and clean it and use it on the next baby. So that meant most babies spent most of the time without this monitor on them. That's changed. So pulse oximetry is a ubiquitous technology now. Every single baby has it 24 hours a day, all the time. So we're able to provide a lot more continuous monitoring from that standpoint than we were, 30 years ago. But I think the NIRS data is showing us that isn't enough, that we need even more monitors, more sophisticated monitors. And I think a lot of where this is going in the future is combining information from these monitors. There's not one single monitor that's going to give us the whole story. It's actually putting pieces together from several of them that will give us a much better understanding of what's going on and what we need to do.
That's the pulse oximeter piece is just, I don't know how to wrap my head around that. That's amazing that you just had it for 30 to 60 minutes and then that's how you were set for the day.
Mm-hmm.
I don't see any additional questions coming through. So I'm gonna just thank you again for taking the time out of your quite busy day, saving neonatal lives and doing all this research, and thank everyone for taking the time out of their day as well.